Welcome, Dr. Shobna.
Chitrakala?
Yes, ma'am. We are live now, ma'am.
Yeah. Good evening, everyone. I am Dr. Deepa Tankamani. On behalf of Chennai Menopause Society, I welcome you all for the Healthy Aging Series 8 from Chennai Menopause Society. Today's CME is Endometriosis at Midlife. To start our program, I invite Dr. Shobna Mahadevan, our Nightingale of Chennai Menopause Society, for the invocation song.
மனதில் உறுதி வேண்டும், மனதில் உறுதி வேண்டும், வாக்கினிலே இனிமை வேண்டும், நினைவு நல்லது வேண்டும், நெருங்கின பொருள் கைப்பட வேண்டும், மனதில் உறுதி வேண்டும், கனவு மெய்ப்பட வேண்டும், கைவசமாவது விரைவில் வேண்டும், தனமும் இன்பமும் வேண்டும், தரணியிலே பெருமை வேண்டும், மனதில் உறுதி வேண்டும், கண் திறந்திட வேண்டும், காரியத்தில் உறுதி வேண்டும், பெண் விடுதலை வேண்டும், பெண் விடுதலை வேண்டும், பெரிய கடவுள் காக்க வேண்டும், மண் பயனுற வேண்டும், மண் பயனுற வேண்டும், வானகம் இங்கு தென்பட வேண்டும், உண்மை நின்றிட வேண்டும்.
Thank you, Dr. Shobna. Next, we'll start with lighting the lamp. Chitra? Midlife prayer. The midlife prayer, we pray to God to give us grace to accept the midlife physical changes and gently renew our strength. Guide our heart, our mind and body to navigate the way and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life, and also for those sitting in a doctor's clinic or who are in bed asking for healing touch. On this day, may all the midlife and menopausal women have the gift of the day, hope and good health. Thank you, God, for the promise of hope you hold out at midlife, hold out to all midlife menopausal women and inspire us. Give this gift of hope to others. Thank you. With this, we'll move on to welcome this CME program. May I welcome Hepzibah Madam, our president, Chennai Menopausal Society. She is a past president of Oxy, and she had many awards, Lifetime Achievement Award, from Foxy TN Medical Universities, and Best Science 2018 Abdul Kalam's Award. And over to Madam.
Yes. A very good evening to one and all. Respected Dr. Shobna Mahadevan. A very good evening to one and all. Respected Dr. Shobna Mohandas, Dr. Sanjeeva Reddy, our speakers, Dr. Ritu, Dr. Damodar Rao, Dr. Ramani Devi, Dr. Vidya, and all the participants. On behalf of Chennai Menopause Society, it's my privilege to welcome you all for this webinar on endometriosis in midlife. I'm extremely honored to welcome Dr. Shobna Mohandas, President-elect, who is a dedicated menopause physician, and she's keen on conducting pan-India study on codfish. Welcome you, madam. And it's my privilege and pride to welcome my friend, Dr. Sanjeeva Reddy, who is a Dr. B.C. Roy awardee and who is a renowned infertility specialist. Welcome you, sir. It's my
Thank you, madam.
Pleasant duty to welcome Dr. Ritu, who is also a B.C. Roy awardee. And I welcome you, madam. And it's my pride to welcome Dr. Ramani Devi, who is well known for her work on endometriosis, both in India and abroad. And I welcome you, Ramani. Yes, my special welcome to endoscopist and infertility specialist, Dr. Damodar Rao. Welcome you, sir. My warm welcome to Vidya, who is an excellent UG and PG teacher from Al Amin Medical College. Welcome you, madam. And we all know the endometriosis is a problematic issue, especially in midlife. But we have a lot of modalities have come, both medical and surgical. I'm sure after listening to the experts, we will have clear idea how to tackle endometriosis in midlife. And once again, I welcome one and all.
Thank you, madam. May I welcome Dr. N. Sanjeeva Reddy, sir, Professor, Department of Reproductive Medicine, to deliver his guest of honor speech. Sir, over to you, sir.
Okay. At the outset, I would like to thank Dr. Hepzibah Kirpamani for involving me in this webinar. She is the president of CMS. She is doing wonderful job conducting so many CMEs. Even though we have so many problems with COVID, one good thing it has done is it has brought the academic activity to the doorstep. So everybody, no need for them to move from their house. And she is selecting all nice topics and conducting many programs. I congratulate you, Dr. Hepzibah Madam, for this wonderful activity doing. Many people, they will be very happy to see their names on the letterhead saying president, secretary, other thing. You are doing really very good job. And when it comes to the topic of today, as you know, the endometriosis, I think many times I will be thinking this is worse than cancer. There it will kill or it will cure. But here it won't kill the patient. At the same time, it won't allow them to be at peace also. When it comes to the infertile patient, the reserve will be very less. It decreases automatically. And also like patients who are above around 40 years, nature itself, there will be decrease in the ovarian reserve. When you have the patient is around 40, in addition, if they have endometriosis, you will have so much problems. We don't know how to manage. So there we have whether to give the medicines or not. When you decide to go for the surgery, when to do the surgery or not to do surgery, what are the precautions to take to preserve the ovarian reserve? And even if you go for the IVF, it is going to give less chance of pregnancy. And how to tackle these problems. Today, she has decided to conduct this webinar, Endometriosis and Infertility around 40 years. I hope it will be very useful to the practitioners. I wish you all the best for this webinar. Thank you for inviting me for this thing. Thank you. Thank you, Deepa.
Thank you for the kind words, sir. Next, I may invite Dr. Shobna Mohandas to give a chief guest speech. She is a president-elect Indian Menopause Society, and she is a consultant gynecologist and laparoscopic surgeon, Sun Medical Center, Thrissur, Kerala. Over to you, madam.
Good evening, everybody. I'm indeed privileged to come to another webinar conducted by my dear friend, Dr. Hepzibah, the lady with the rose. I can't see your rose today. What happened? There. Okay. It's lovely to see Hepzibah with the rose everywhere. And Chennai Society is a home next to home for me because I've come there several times, and Tamil Selvi and Hepzibah, everybody has come here. Especially, I'm very happy to be seeing my dear friend, Dr. Vidya Tobi. She's the one who taught me what is Zoom. One day she calls me up and, Shobna, you have to come for menopause meeting. How do I do it all? It's all Corona. You do it on Zoom. What is it? I said, Zoom. I thought she's making fun of me. No, Zoom. And then she teaches me what is Zoom. And this is how I came into the world of Zoom. Thank you, Vidya. And Menopause Society is a great place to be in. After your Food and Drug Committee, I hope you will start a Menopause Society in Bijapur. I keep telling you. And we need you in Menopause Society also. You have come for the CIMP. I am very sure that you can start a society in Bijapur. I also appeal to Dr. Ramani Devi also to start one in Trichy after the vice presidency is over. So we need more and more stalwarts to come into Menopause Society. It's a great place to be in, and we have people like Hepzibah and many others. You will have a lot of friends. Coming to the topic, yes, the topics are very well chosen because we have been practicing endoscopy for so long. Medicines in endometriosis, Dr. Ritu Khanna is going to talk. And I remember in 1989 or something like that, one patient came with rectal bleeding during the time of periods, and I had given a medroxyprogesterone acetate for 3 months and stopped it. And I was feeling deja vu. Can you imagine? And like I diagnosed it on that. And that's like today we have so many advanced surgeries, but still, or the uninitiated, again, medroxyprogesterone acetate for 3 months, they may have to depend on that. Today, when do I give this medroxyprogesterone? People who cannot afford Dynagest, or somebody who's taken Dynagest for 2 years because the bladder is gone over the fundus of the uterus and come to the back of the uterus. I've seen patients, when you put a scope, the bladder is going over the fundus and even encroaching the back of the uterus. How do you operate on that without taking consent for colostomy and cystoscopy, everything? So then again, back to medical treatment. So, 89 and 2020, again, you have to go back to medical treatment. We have to know about it. And when I was Damodar's age, probably I used to sit and operate on endometriosis, and I used to be so careful, not touching here, not touching there. Then the anesthetist would come and tell me, Arey, your husband only can make her pregnant. You sitting and touching on it so long is not going to make her pregnant. So that you have to take so long to do a case on endometriosis, because you cannot do it fast like an LAVH. You have to be very careful, and I'm sure that he will tell us how to do it. And recurrent endometriosis is a problem. Not many of my patients have come back with recurrent endometriosis, unless they were having bowel endometriosis, where you have to leave a little bit of the ovary with the bowel so as not to cut the bowel. I am not one person who can cut the bowel and suture it. So in such cases, they do come back with recurrences. Otherwise, a very well done surgery. Generally, 10-15 years, they come back with their children or other relatives. We don't see recurrences. You do a very good surgery on endoscopy. So all the medicines in endometriosis, yes, patients always say, what did I do wrong? What can I eat so that I won't get endometriosis? And I don't know whether we say that biryani ka, that cinnamon and everything is good, and fruits and vegetables are good, don't eat meat. But then I don't know if Vidya Tobi will give some succor to our patients and say that eat well and avoid Damodar. So we don't know. Let's see. So with all this beautiful speakers and wonderful speakers in this podium, I'm sure you'll have a good time. And thank you, Hepzibah, for inviting me once again, and wish you all the best for a good.
Thank you, madam. With this, with this inauguration, we'll move on to the.
No. Dr. Shobna has to release the newsletter.
Okay.
Ask Dr. Shobna to release the newsletter.
Yeah. How do I release it, Hepzibah?
Yes.
I will just pronounce that it is released.
Release on its own.
Okay, so I just, okay, Hepzibah. I'm honored to have released this any newsletter, any written matter. It takes hours of work to check the words, check the English, check the everything. And I don't know how many people read it, because still the person who writes it becomes very expert on writing it. That's what I realized by writing books, and I stopped writing books because of that. But you have taken this effort to collect these photographs. You don't know how many hours of work goes into writing a newsletter. I really congratulate you, and you are a continuous worker. I wish the world has more like you, publishing newsletters, giving support to so many people, encouraging hard work and not encouraging drug abuse. More and more people come with encouraging things like this, the world will be a better place to live in. So, happy newsletter.
Thank you. Thank you so much. Thank you, Dr. Shobna, for releasing the newsletter.
Thank you, ma'am. So we'll move on to the CME program. I'll invite our chairpersons, Dr. G.S. Santi. She's a professor and head of geriatrics, Madras Medical College, Chennai. She also have a gynecologist. She's finished a diploma in gynecology, and she's also a practice gynecologist. And she's a past president, Indian Academy of Geriatrics. And she is an active member of SCARF Chennai. She had missed paper awards and judging the oration syncope in elderly and Trivandrum oration in assessment of prevention of falls in elderly in Indian Aging Conference in 2016 at New Delhi. Over to you, madam.
Yeah, thank you. A very good evening to all of you. With a nice introduction given by our guest of honor and the chief guest, we will move on to the CME session, that is health under the Healthy Aging Series 8. We are dealing with the endometriosis at midlife, and in this first session we have two topics, that is medical management of endometriosis and followed by fertility sparing surgery for endometriosis. So to address the first topic, the medical management of endometriosis, we have with us Dr. Ritu Khanna. She is a very holding very important key positions in various organizations. She is the chairperson of FOXY, Secretary of Society of Fetal Medicine Update, Chapter 21 to 24. She is also a Central Executive Committee member, Society of Fetal Medicine. And she's Vice Chairperson, Women Doctors Wing, Executive Member of COG to 21-23, Vice President, and also she's got so many posts, Joint Treasurers, Convener of IFS Ultrasound in 18 to 20, Scientific Secretary, and so on. And she's also his key work is on exclusive single embryo transfer. I think this will have a very good future. And she's also awardee of BC Roy Memorial Award in 2018 for her outstanding contribution in the field of gynecology. And she also had she has delivered a presidential award 2021. And she also is Best West Chapter Award as Secretary of UP Chapter, and she's got so many awards, and I think it's very time consuming to mention everything. And many publications also she has, and her main interest is on laparoscopic and hysteroscopic fertility enhancing procedures. She is also in charge of a center recognized by the FOXY for infertility. So over to Madam, so that we can listen to the medical management of endometriosis, which is going to be the talk. Over to you, Madam.
So thank you so much, Shanti Madam, for the very, very kind words. And my gratitude to our chief guest, Dr. Shobna Mohandas Madam, who's the President-elect Indian Menopause Society. And also the guest of honor, Dr. Sanjeeva Reddy Sir. My heartfelt thanks to Hepzibah Ma'am, the President of Chennai Menopause Society, Talmi Sylvie Ma'am, the Secretary, and Deepa, of course, for inviting me here in this focused academic session of Healthy Aging Series 8. And so happy to see changes, not challenges. And my thanks also to Ramani Madam also. And though I had another session, but it's all the love and affection, Ramani Madam or Hepzibah Ma'am. And also I'm here because of all this, which brought me here today. And I can never say a no to them. And my regards also to Vidya Thobi Madam and Dr. Damodar Ram. So with this, I begin with the medical management of endometriosis in the midlife. We know that it's a benign yet invasive, high post-therapy recurrence rate, and no cure eradication in sight. It's a chronic disease, the therapy throughout the menstrual life, and an inflammatory disorder. Yes, of course, if we look into the impact on the life, just look at this, the sexual life, 50%, the relationship with family, 36%, and so on and on. So that's how it keeps troubling us all the time. So what was the perception? It was that endometriosis is an estrogen-dependent inflammatory disease, which is characterized by the presence of endometrial tissue, and the disease mainly occurs during the reproductive years and is rarely diagnosed after the menopause. But if we look into the data over here, we find that 64% was less than 30 years, and yes, still we find a 7% which is still left further. So does it still exist or is still active in the menopause? Due to the steroid-dependent nature of the disease, most women with endometriosis express the regression of the disease after menopause. But still, a number of women experience endometriosis-related symptoms after natural or surgical menopause. And additionally, the women with a history of endometriosis may experience worsening of symptoms and reactivation of the residual disease with the use of hormonal therapies aimed at relieving the postmenopausal complaints. So the perception now changing into a reality. The paradigm shift from the belief that endometriosis only affects the women of reproductive age has drawn attention to endometriosis in both the premenarchal and the postmenopausal patients. There is still scarce information in literature regarding the postmenopausal endometriosis, and the most studied and reported being the prevalence in the postmenopausal women. Now, if we look into the prevalence here, the prevalence of endometriosis is less than 3%. An early series showed somewhere between 2 to 5% of the postmenopausal women being diagnosed with endometriosis were within 7 months of their menopause. And more recent studies looking into this big study of 42,079 German women, it was confirmed that endometriosis is in 2.55% of the women were postmenopausal. So it represents a side effect of HRT, rarely occurring in patients without a history of HRT or tamoxifen treatment. There could be recurrence of endometriosis lesion in patients with prior diagnosis of the endometriosis during the premenopausal period, or a de novo appearance of endometriosis in the postmenopausal patients who had no prior history of endometriosis-related complaints in numerous case series, reports, and retrospective studies that we have. So the pathogenesis is really an enigma. The arrest of estrogen at a level of the ovaries at the time of the menopause is now being counterbalanced by the peripheral estrogen production from the conversion of the androgens. With no history of MHT or surgery, the theoretical coelomic metaplasia etiologic mechanism could really explain the occurrence of the postmenopausal ovarian endometriotic lesions. A lot of investigations going on now suggest that some interleukins play a main role in endometriosis pathophysiology by allowing these ectopic endometrial cells to go and get implanted and grow or trigger a coelomic metaplasic etiologic mechanism. So it's been postulated that some postmenopausal women could have a relative immunocompromised status and therefore the lesions to establish and progress, of course. There's so many new theories about pathogenesis which suggest that it may originate from a Müllerian or a non-Müllerian stem cell, including those from the endometrial basal layer. The innate ability of this endometrial stem cell to regenerate cyclically and seems to play an important role. And there's evidence to support the ectopic Müllerian remnants of the endometrium, which are leaked out from the genital ridge during the organogenesis. So another theory is the dysregulation of the hormonal pathways, as it's been evidenced by increased estradiol or a progesterone resistance, which has also been widely accepted. In addition to the peripheral estrogen production, a high circulating level of the estrogen, which may be an external source, especially in the form of a phytoestrogen and the HRT. The phytoestrogen appear to exert estrogenic effects on this uterus, the breast, the pituitary, and could also support the growth of these endometriotic lesions. Whenever we have these endometric implants, aromatase is being expressed, and the utopic endometrium of the women with endometriosis The autocrine paracrine effects result in the production of estrogen. And this estrogen stimulates the COX-2 in a positive feedback loop, which thereby increases the formation of prostaglandin E2 and therefore the increase in the aromatase activity. If we looked into the immunochemical profile, the postmenopausal, it's almost the same as a premenopausal, and it has a potential to reactivate whenever there is an estrogen stimulation, and therefore they would be less active otherwise. And this women could present to us at a age of menopause, unspecific or pelvic or ovarian cyst or some intestinal symptoms. And in menopausal women with a history of endometriosis, a drop in the estrogen levels after menopause relieves her of the endometriosis, but really generates another specific menopausal symptoms of mood swing, flushes and all. The patient's medical history, clinical history, or a preoperative have got a very limited role in determining the extent of the endometriotic lesion, because there is no direct relationship between the symptoms and the anatomic surgical characteristics of the endometriotic lesions. And a long gap right from the symptoms start till the diagnosis is a very big, long period of 7 years. The pelvic vaginal rectal examination, we could find some nodules in the posterior compartment, but the clinical examination may be normal in many patients who are getting a deep infiltrating endometriosis. The malignancy consideration should always be taken in these patients, irrespective of the symptoms, and therefore we need certain diagnostic modalities. And I think laparoscopy still stands as a gold standard for diagnosis of endometriosis. The transvaginal has gained a lot of interest. A first-line investigation, which is non-invasive and explores the pelvis, quite widely available. It's very cost-efficient and it's very well tolerated. Yet no imaging method can definitely confirm this diagnosis. The CT scan plays a major role in diagnosis of a bowel endometriosis in the presence of colon distension. The MRI, of course, non-invasive diagnostic method for a deep infiltrating endometriosis. So regarding the imaging investigations, we have the MRI and ultrasound, which are very important, but findings are more difficult to interpret in the menopausal patients than in the younger ones because of the higher suspicion for the neoplastic lesions. No serum marker to date, but human epidermis protein 4 is a robust tutor marker now, has a comparable sensitivity to CA125, but a significant high specificity in differentiating endometriosis cases for malignancy and may be used in future. So either it could be a recurrence or a malignant endometriotic lesions. Sometimes these patients may have needed an early hysterectomy or a bilateral salpingo oophorectomy because of the endometriosis. And now these endometriotic lesions may recur because she used a menopausal hormonal therapy. The prominent risk for the recurrence among women receiving this were peritoneal involvement which was more than 3 centimeters. Tamoxifen represents a hormone substitution in these postmenopausal women with breast cancer. It has anti-estrogenic effects on the breast tissue, but yes, promotes endometriosis to certain unknown mechanisms. The first case, 1993, who had received tamoxifen for 2 years due to breast cancer, another operated breast cancer and adjuvant tamoxifen. But during the next year, so many authors reported cases of ovarian and endometrioid who had used tamoxifen, considering no significant statistical evidence. The relation between tamoxifen and malignant transfusion still may be coincidental. So the risk of a malignant transformation into an ovarian cancer is as high as 2 to 3%. In patients, it's much higher in receiving estrogen therapy. In the postmenopausal women who underwent surgery for endometriosis, the hormone therapy remains controversial. So postmenopausal hormone therapy may increase the risk of malignant transformation or recurrence of this endometriosis, but still we need more data to confirm. The endometriotic cells share features with the malignant cells that they're able to proliferate, they're able to survive in an ectopic environment and to metastasize to distant locations. And this risk increases after menopause with the use of the unopposed estrogens. So as endometriosis is composed largely of the ectopic endometrioid tissue, this implies it will be sensitive to a reactivation or a transformation to malignant form if exposed to estrogen. So endometriosis associated with around 50% increase in the risk of epithelial ovarian cancers. And of course, we need to differential diagnose for the same. Extrapelvic endometriosis is rare clinical in the postmenopausal women. It affects slightly older population because it's going to take several years for the pelvic endometriosis to metastasize outside the pelvis, and therefore statistical data regarding this is very limited. And most common locations when it's extrapelvic is a GI tract followed by urinary tract. So now the impact of the hormone replacement in women with a history of endometriosis, the risk of HRT is considered to be linked to the residual disease after surgery. The data regarding the hormone therapy is very scarce. They may have used a continuous combined estrogen progesterone or a tibolone in patients without hysterectomy, considered to carry a lower risk as compared to those who had been using estrogen. The use of HRT raises concerns about the disease reactivation, the recurrence of pain, and the need for surgical treatment, and even malignant transformation of residual endometriosis. So the risk of a malignant transformation with a history remains a matter of debate still. The long-term follow-up studies are needed to evaluate the risk of such an adverse outcome, and further studies still are mandatory. A de novo endometriosis could appear especially when there has been an unopposed estrogen therapy or there has been obesity. The postmenopausal women with symptomatic endometriosis could be managed surgically, removing all the visible lesions because of a high risk of recurrence and malignancy. So I think till now, surgery still signs the first line of management. But what about the medical therapy? It can be used in the cases where there is a pain recurrence after surgery, or if the surgery has been contraindicated, there are additional comorbidities which represent an additional risk to the contraindicated surgery and include advanced age or maybe pelvic adhesions from the previous surgeries. 12% of them will finally require a hysterectomy without oophorectomy. So aromatase inhibitors, yes, they can be used as the first-line treatment when surgery is contraindicated or as a second-line treatment after surgery. Aromatase can act by decreasing the extra-ovarian estrogen production and by blocking the feedback stimulation loop between inflammation and the aromatase within these lesions. In addition, the P450 aromatase enzyme, which converts androgens into estradiol, appears to be overexpressed in these tissues, although no data available in tissue from the postmenopausal women. So they have shown to be effective, the aromatase inhibitors, to reduce the endometriosis-related pain in the premenopausal, also with severe endometriosis, but in postmenopausal, only case reports available with the aromatase inhibitors. And we saw this forward, the estrogen stimulate COX-2 in a positive feedback, which increases the formation of prostaglandins and increases the aromatase activity. Thus, its theory could explain how endometriosis lesions may persist and become symptomatic in the hypoestrogenic environment after the menopause. So these aromatase inhibitors will act by interrupting this local feedback forward loop and thus reducing the intra-regional estrogen production and could be an alternative treatment for the postmenopausal endometriosis. So the two reviews describe 6 case reports which mention the administration of aromatase inhibitor for a period from 4 to 18 months, which improved the pain, reduced the recurrence also, and the other studies also. But aromatase inhibitor would impair the bone mineral density and need to be supplemented by a bisphosphonate therapy also. So aromatase letrozole 2.5 milligram daily could be used, of course, reversible, more potent, faster acting, but yes, we need to take care of the bone loss in the long-term use. Progesterone administration, oral or intrauterine system, had been proposed as a reliable alternative treatment in patients with contraindicated for surgery. Levonorgestrel exerts a local effect on the endometrium. It's going to induce the atrophy. This direct local effect could be of interest for treating the endometriosis symptoms in the postmenopausal women. But till date, no extensive data is available and further studies were needed regarding this progesterone use in the postmenopausal endometriosis. So LNGS controls endometriosis-related pelvic pain, and it releases 20 micrograms of hormone per day over a 5-year period, delivers this progesterone locally. It avoids all the systemic side effects, causes atrophy, and not only this, it also takes care of the immunomodulatory functions. So LNG IUS can be continued after menopause and can be used in conjunction with an estrogen for HRT. So several small randomized controlled trials have compared this LNGIUS with postoperative expectant management or the other hormonal treatments for endometriosis-related pain symptoms. And the studies have shown that yes, there is a reduction in the severity of endometriotic lesions at laparoscopy and a reduction also in the size of the rectovaginal lesions on ultrasound in response to the LNG-IUS treatment. So if we go into the medical management or the algorithm, the postmenopausal suspicion of endometriosis, pain or imaging depicting laparoscopy, yes, diagnostic confirmation. The first and the foremost that we do exclude all malignancy and we need a pain relief. If there's a pain ongoing or a recurrence, medical treatment with aromatase inhibitors or the progestins or LNG-IUS. And this was one study because of just finding out, and the data was really scarce. And this was the Orchidia study where we did it this was done in 18 to 45 years of age. And they gave these patients dydrogesterone 10 milligram 2 to 3 times daily, either between 5th to 25th day of the menstrual cycle or continuously. And they found that a prolonged cyclic and continuous treatment of dydrogesterone demonstrated a pronounced and similar reduction in severity of the chronic pelvic pain and dysmenorrhea and led to marked improvements in all the study parameters related even to the quality of life and the sexual well-being. Now, this was a very attractive theory regarding the pathogenic mechanism, which says estrogen threshold. When a certain estrogen level is reached or surpassed in the postmenopausal, it activates all the undetected transient foci of endometriosis. The estrogen concentration that causes the endometriotic lesions to grow or regress varies among women, but a concentration less than 20 picograms usually causes the regions to regress, and a concentration more than 60 picograms usually supports the growth and maintains the lesion viability. So estradiol concentration below 20 may cause the lesions to regress, and is also associated with certain moderate to severe hot flushes and accelerated bone loss. So estrogen threshold hypothesis then gently suppresses estradiol to have the concentration somewhere between 20 to 45. And this may simultaneously cause endometriosis lesions to regress, resulting in a reduced pelvic pain and minimal blood loss and few hot flushes. So I think this could be used as a therapy for formulating all the medical management for these postmenopausal women. So despite relatively low incidence of endometriosis in midlife, the physicians should consider endometriosis in cases of non-specific pelvic pain in these postmenopausal patients, even if the patient has no prior history of any endometriotic lesions. And this postmenopausal endometriosis seems to expose the patient to a higher risk of a malignant transformation, and the absolute risk of a disease recurrence and the malignant transformation can really not be quantified, and the impact of HRT use on these outcomes is really not known. So multicentric randomized trials or large observational studies are still required to unveil so many facts to bring forward more and more into the medical management of endometriosis. Thank you so much for a very patient hearing.
Thank you, madam, for your nice elusive talk on this endometriosis, covering the midlife endometriosis as well as an exhaustive postmenopausal endometriosis management, including the hormone therapy, the aromatase inhibitor therapy, GnRH role, and also the LNG-IUS, how it is useful in the postmenopausal. You have highlighted very clearly. So that was a very nice hearing to your talk on endometriosis, madam. Any questions or anybody would like to add any points? I think she has covered it exhaustively, all the areas.
Have you tried aromatase inhibitors in this endometriosis, Dr. Ramani Devi or Ritu Khanna?
I am, see,
I've heard of Ramani Devi
I'm using a lot of letrozole and progesterone support, because patients who fail to respond to surgery, or even some patients who are put on leuprolide acetate, long depot, they do not respond. In such patients, I am very fond of giving letrozole with progesterone supplementation.
How many years have you given it?
Pardon? Pardon?
How many years you would have given? I've had a patient whose bladder was in front of the uterus and she took this Dynages for 3 years. I thought, I don't know where she went off, and after 3 years, she comes back to me saying, Madam, I'm still taking that drug. So that way, I don't know. So, do you have any experience? How long do you give this letrozole?
Letrozole, I think maximum 6 months only we can give, because beyond which there is definite chances that the bone mineral density comes down. But with the study with the Dynages, you can use for n number of years. Long-term studies are there. So I think that patient was quite encouraged enough to continue Dynages. Probably when she had... pardon?
I just went into the studies. So at least minimum of 4 months, at least these patients require. And the studies which I tasted given up to 18 months. But yes, the bone mineral
density
needs
so
to
that is why we have to combine with progestin.
Yes,
And probably I have combined with GnRH analogs, especially goserelin, that gives excellent pain relief. That is my observation from recurrent endometriosis patients.
Madam, any experience of combining the bisphosphonates along with this letrozole to avoid this bone resorption?
Yes, theoretically, we can always give probably the addition of progestin that reduces the BMD reduction. And we always supplement these patients with calcium. And it is wiser to do a BMD analysis if they are put on long-term GnRH plus letrozole group, then treat accordingly. It is basically scientifically, it is correct, because even in a normal postmenopausal women who have BMD reduction, we put them on bisphosphonates.
Okay, madam. Thank you.
LNG-IUAs is very good for that rectovaginal endometriosis. Some
Yes.
patients, they get very good relief.
Correct. 100%. 100%.
Yeah. So that's it.
Oh, shall we move on to the next topic of this session? That is fertility sparing surgery for endometriosis.
Madam, one small request.
Shanti, Dr. Ramani will be talking on recurrent endometriosis.
Because I have to.
Yeah. But she knows that you are talking only the topic, she has changed it.
Okay, over to Dr. Ramani. So a brief note on her. She is the Managing Director of Ramakrishna Medical Center and Janani Fertility Center. And she has won many gold medals, underwent IVF training in London. And she's also a Diploma National Board teacher of CSI Mission Hospital for 5 years. She has won many prizes, that is Professor C.S. Dawn Prize.
Madam, I think you can stop with that, madam. I think you can stop.
Yeah, she's got a very lengthy CV, and she is just like to mention she is a recipient of Best Women Doctor Award by Tamil Nadu State Indian Medical Association, and also many awards like MS Ashraf Award, Duru Shah Distinguished Community Service Award, and so on. She is also National Vice President of FOXI and a peer review member of JOGI and ARCOG, and editorial board member of International Journal of Human Reproduction. And she is also EC member Society of Vaginal Surgeons of India. So over to Madam for her talk.
Thank you, Shanti Madam, for your, I'll start sharing mine.
Yes.
So after Dr. Ritu Khanna's excellent talk on perimenopausal endometriosis and how to handle it, I'm going to talk on something about recurrent endometriosis, which we find very, very common. So now the points for discussion will be why there should be recurrence in spite of good surgical technique, why there should be recurrence, and how to diagnose the recurrence, how to prevent it, and if at all it comes, how to manage it. So this 5 to 10% of the women of reproductive age group, they have endometriosis, and 30 to 50% of women with endometriosis are infertile, and vice versa. So that means if a patient in the reproductive age group has got an endometriosis, before she completes her family, there are high chances that recurrence can happen. So in such situation, we have to deal with the recurrence and promote her fertility. So probably that is why ASRM has given a definition that it should be viewed as a chronic inflammatory disease that requires a lifelong management plan, meaning that starting from adolescent, from till the even the postmenopausal age, the patient needs a lifelong management plan with the goal of maximizing, you try to utilize more and more of medical management and avoid repetitive surgical procedures. So it is something, all of us know that endometriosis is a benign disorder, but it behaves like a malignant lesion because of its invasiveness, because of its recurrence and failure to respond to routine treatment. And Ritu Khanna had beautifully showed how it affects the quality of life by giving some statistical data. And apart from that, there is economical loss by the way of work loss, expenses for medical and surgical treatment. It seems if there are $120 billion are spent just for the health and taking care of these endometriotic patients. Again, it leaves a morbidity that is in the form of pain, infertility, sexual dysfunction, and recurrent surgeries. So what is the incidence of recurrence? The recurrence may be just the reappearance of the pain. After 1 year of surgery is almost 50%, 45% they have recurrence of pain. And reappearance of the disease by USG and clinical examination is up to 19 to 15%. And even after conservative surgery and 6 months of medical treatment, 1 year later, 26% they have pain recurrence and 8% have detectable disease. So all of us know about the pathogenesis of endometriosis. Why I am stressing this is your surgical management is not going to look into the pathogenesis. The pathogenesis persists. So that is the estrogen is the culprit, where it acts upon the ectopic endometrial cells by the retrograde menstruation or the coelomic metaplasia theory or the immunological theory. And so many new theories, including the stem cell theory, has come up. And these basic pathogenesis is not altered. It leads to invasion, angiogenesis, oxidative stress, chronic inflammation, and ultimately you develop this endometriosis. Then one more thing is, there is alteration of the progesterone receptor changes in endometriosis. See, normally the progesterone receptors are A receptor and B receptor, and the B receptor is the one that is actually needed. It should be upregulated. But in endometriosis patient, there is overall downregulation of both A and B receptors, and more so the B receptors. That is why you have the manifestations, because there is progesterone resistance basically in endometriosis. The recurrence of the lesion occurs. Why the recurrence occurs? Maybe they are the newer lesions that are developing after surgery because you are not correcting the basic pathogenesis. Second point is it could be a reactivation and persistence of the existing lesion because they are not totally surgically corrected, and the surgery is only cytoreductive. And again, the basic pathogenesis is not addressed by surgery. It could be also lymphovascular involvement. That is another reason for recurrence. More often that is seen in rectovaginal endometriosis. And endometriosis mimics malignancy, and that is a reason why there is recurrence, because the gene that is causative agent for the ovarian malignancy and endometriotic malignancy are almost the same. Estrogen receptor polymorphism, estrogen receptor APL may be responsible for increased propensity to the recurrence. So there is immunological role. NK cell suppression is seen in endometriosis. Macrophages behave abnormally. Instead of causing suppression of this endometriotic tissue, it causes activation of the leukotrienes and the cytokines, which will aggravate the disease process. This basically depends upon the genetic and immunological factor. Treatment, either medically or surgically, it is not going to address the etiological factor, but it can only reduce the burden of the disease. So then again, aromatase is gaining very much importance, aromatase activity. Medical treatment will increase the apoptosis, decrease the proliferative activity, and estrogen biosynthesis by the ovary. Whereas the biosynthesis of estrogen in the peripheral tissue and in the endometriotic implants, because each endometriotic implant acts as an apocrine gland, where there is increased aromatase expression. These things are not suppressed by our routine drug, but whereas the aromatase inhibitors can be used to suppress this peripheral as well as the local production of aromatase. There are certain risk factors to find out whether the patient is likely to have recurrence or not. The patient with a low risk has got always an initial revised AFS score of less than 70. Previous pregnancies, when the patients are put on continuous oral contraceptive pills or COCs or progestins, Endometrial ablation, unilateral lesions when there is a perfect complete surgery, postoperative medication for a long time and a thin individual. But whereas if the patient has got an initial revised AFS score of greater than 30, that means when it is a very severe, moderate or a very severe lesion, bilateral masses, suboptimal surgery, and when the patient is not advised proper postoperative medical management, and always the younger the patient, the likely recurrence is quite high, family history, and again, history of ovulation induction drugs for IUI might increase the recurrence, but not IVF. So how to diagnose? The symptom recurrence in patients following conservative endometriotic surgery. And again, the first thing is a symptom recurrence. The second one is the radiographic evidence of endometriosis, like recurrence of reappearance of endometrioma that is detected either by ultrasound or MRI, or findings in the clinical or second look laparoscopy, and elevation of CA-125 following surgery. Mind that CA-125 can be used only for follow-up, not for the initial diagnosis, because it is quite non-specific. So the recurrence rate, review of literature shows conflicting results. The rate may vary greatly because the definition of recurrence differs. It could be symptom recurrence, clinical recurrence, or biochemical recurrence. So why recurrence rate differs? Definition of recurrence differs. There is no uniformity about the terminology, phenotype of the endometriotic lesion, surgeon skill and the technique used, type, dose, and duration of the postoperative medical management. So what are the definitions for symptom recurrence? The patient usually comes back with a history of endometriosis pelvic pain, which is getting aggravated, and there is an increase in the standardized measures like by visual analog scores. The pain goes beyond 5 to 10, and then there is decrease in the quality of life. So if you look into the phenotypic lesions and the recurrence rate, the recurrence rate seems to be higher in patients who are treated for ovarian endometrioma. And that is somewhere about 12 to 30%. And for the superficial endometrial peritoneal endometriosis, it is 4.1% at the end of 1 year and 6.7% at the end of 2 years. Since conservative treatment is invariably followed for this superficial peritoneal endometritis in the way of cauterization or laserization. Deep endometriosis is associated more often with endometriosis associated pelvic pain than the other two phenotypes, and usually surgical correction is quite, unless it is being done in a center of excellence, these deep endometriosis are often undertreated surgically. So that could be another reason why it is recurring. Then dilemmas are, it may be because of inter and intra-observer variation. The clinical nodule, clinically when you examine, if you feel a nodule, it can be mistaken for a fibrosis, and we do not have a visual or histopathological examination. Definition of recurrence based on clinical finding can often overestimate the true incidence. So again, when you look into the size of the endometrioma, which you say is recurrent, it is 1 to 2 centimeters by ultrasound, depending upon the study. And Serraccioli et al. Studies shows that the cutoff point could be 1.5 centimeters. And some authors suggest that pain could be associated with ultrasound finding of small cysts, which are quite normal, benign cysts, which are normal after surgery. And if it is going to be functional cyst, usually it will disappear within 2 to 3 months. See, this was one of the largest study by Sun B. Gyo, where he had followed up the patients for 23 years, and he found out that 21%, 5% of the patients have recurrence at the end of 2 years, and 40 to 50% at the end of 5 years, in spite of the experienced surgeon doing the surgery. Then the next question is how long to follow up. The data from recent large case series have documented that recurrence as high as 30 to 40% occurs at the end of 2 to 3 years of follow-up. 2 years after surgery could be the minimum follow-up period, but because the newer lesion, they take around 2 to 3 years to reappear and get visualized. And many of them, they are lost follow-up if the timing is prolonged beyond 2 to 3 years. And ideal is lifelong, or at least up to menopause, but I would say minimum period of 3 years is essential to follow up the patient. So at the end of the first procedure, at the end of 5 years, the recurrence rate is 20 to 40%. And more often, 1/3 of the patients with endometriosis, they undergo recurrent repetitive surgeries. And by the end of the second procedure, it could be even 17%. So this was a study that was recently published. What are the recurrence patterns after surgery in patients with different phenotypes of endometriosis? This was a long-term study where they had followed up for a period of around 240 months. They found out none of the phenotypes have got a lesser incidence of recurrence. See, almost they have a high incidence of recurrent. It is almost parallel. So that means whatever be the phenotype of the endometriotic lesion, the long-term follow-up says the recurrent rate is not lower, it is almost the same. So how can you find out the recurrence? It is by simple imaging modalities. If the size of the endometrioma is beyond 1.5, we can find it out by a simple ultrasound, or maybe you need to have a CT scan or an MRI. So MRI will be better. Again, I said CA125 and the incidence of recurrence. Busaka studies showed that usually a rise in CA125 alone or in association of the pain recurrence and clinical recurrence or ultrasound evidence, we can 100% make sure that the patient has got recurrence. Then there was another multicentric study by Parasasni et al. The overall recurrent rate was assessed on clinical ultrasound and CA125 elevation, revealing 4.6 and 9% recurrence rate respectively at the end of 1 or 2 years of follow-up. So the biomarkers, I think I can skip this. There are combination of biomarkers which are essentially, they can predict the occurrence of recurrence. That is COX-2 overexpression. That is one important factor. And then again, decreased progesterone receptor isoform B, increased nuclear factor kappa B. Together, they yielded a prediction for recurrence rate with a sensitivity of 86% and specificity of 82%. So the most important gold standard in diagnosis of endometriosis and management is only laparoscopy and laparoscopy. So when do you do laparoscopy? Laparoscopy is done when the medical management fails. So the aim of our primary treatment should be to have a complete cure, but that is not possible. So probably we can delay the recurrence, reduce the pain and treat the infertility if the patient is keen on infertility management. So the data in favor of the growth. So the recurrence can be in the same area as the original disease. If you remove the endometrioma on one side, right side, say suppose, on the same side, it can recur in 81% of the patient, or a contralateral untreated ovary, it can happen in 11%, or bilaterality, it can happen in 8%. So all are proven only by animal studies. Probably we need a long-term follow-up of our in the patients. So how do you prevent recurrence? Initial surgery done by the best surgeon, clearance of all endometriotic lesions, even a small atypical lesion should not be overlooked. That can also lead to the persistence of the lesion. So the endometriotic surgery, if you are going to be more radical, then it is going to impair your ovarian reserve. And if you are going to be less radical, it is going to recur. So we need to balance how much we need to remove. So the first thing is timing of surgery is very important because it should be done in the follicular phase. And the recurrence was twice and remission was shorter when they found that the patient has undergone surgery in the luteal phase. Again, the type of surgery also matters. The ideal thing is do not do the surgery when the patient has been put on some medical management because it can suppress the earlier lesion, minor lesions in the peritoneum, and we are likely to miss it during surgery. So better to wait for some time, few months, 1 or 2 months after the surgery, after the medical management, then proceed with the surgery. So if you're going to go with the surgical superficial endometriosis, the primary treatment, either you can cauterize or laserize, and butterfly excision of the peritoneum or excising the entire peritoneum in the pouch of Douglas, where it is being infiltrated with the superficial endometriosis is being done. That is supposed to reduce the incidence of recurrence, but we have to understand that the chances of additions in the pelvis is more common in such radical procedures, and especially when the patient is keen on fertility. Then ovarian endometrioma, when you do a cyst aspiration, surface cauterization versus cystectomy, an ideal procedure is to go for a cystectomy because cystectomy definitely reduces the recurrence rate. The deep endometriosis is managed in center of excellences where you can go for shaving of the deep endometriosis, discoid excision, or segmental resection and anastomosis can happen. So again, this is what the technique of the surgery is. Better to go for a cystectomy, not to go for just a simple drainage, because it is going to cause recurrence very early. An ideal thing is in radical surgery is mandatory to prevent the recurrence in patients who have completed the family. So the effect of post-medication on recurrence risk. Eliminate the risk. Theoretically, it is supposed to eliminate the residual endometriotic cells by medically attacking that endometriotic lesion. Then recommendation is post-operative medical management should be instituted to minimize the risk of recurrence, and hence it should be continued for a longer time. That will promote the pain-free period. So the duration is minimally, at least for a period of 2 years, we need to continue the post-operative medication to prevent the recurrence. So again, this was a study that was in a recent 2021 study, endometriosis recurrence following post-operative hormonal suppression, a systematic review and meta-analysis. The conclusion was when hormonal suppression, either COCs or progesterone or LNGIOs or GnRH agonists are initiated within, rather I would put it as early as possible, there is a significant reduction in the endometriosis recurrence and pain scores at the end of 1 year post-operatively. Medical suppression should be considered and discussed with the patient not seeking pregnancy immediately. Otherwise, if the patient is keen on pregnancy, then she has to be directed towards the management. So various hormonal agents are shown to be very effective. Choice of treatment should be individualized according to the women's need. For example, if the patient has got an adenomyosis with endometriosis, then probably my choice of treatment will be an early 2 or 3 doses of GnRH, which will reduce the size of adenomyosis plus suppress the endometriosis. Then when we insert LNG-IUS, it takes over and it gives a very good relief. That is what generally in patients who have completed the family, when they are having unilateral endometrioma, surgical correction, that is probably removal of the right salpingo-oophorectomy with followed up with GnRH analogs and LNG-IUS can be of use. But COCs now they have been put on the second line group of drugs for prevention, though it can reduce the pain, endometriosis associated pelvic pain. But once when you stop COCs, the chances for recurrence is going to be high. So about LNG-IUS, I have discussed already. Immediate post-operative use of LNG-IUS reduces the recurrent state of pain and reduces dysmenorrhea at the end of 10% at the end of 1 year, and compared to 45% at the end of 1 year in non-users. So Dynages is another excellent drug which can be used for a long term. Beyond 10 years, it has been tried. And so similar to cancer chemotherapy, we can try a combination of progestin or a COCs or a Dynages or a LNG-IUS or a GnRH analog. So this was another study published in 2020, Dynages and the risk of endometriosis recurrence following surgery, a systematic meta-analysis that shows they found out that they had a very low risk of post-operative disease recurrence when the patient was put on Dynages for quite some time. So again, this was another systematic review and meta-analysis, which shows that use of Dynages that was done in 1,184 patients who were given 2 milligram of Dynages for a period of 29 months, which was supposed to reduce which had significantly reduced the recurrence of the endometriosis. Suppose if there is recurrence of endometriosis, then we need to, so far we have looked into how to prevent it. But if the patient has got a recurrence, then ideal is to manage the patient initially with medical management with all the above said drug. And the most important, I would say currently is getting popular is aromatase inhibitors. So if then again, if the patient is not getting relief with the medical management, maybe we need to go for a surgical correction, where definitive surgery, if the patient is nearing perimenopause, maybe to hysterectomy with bilateral salpingo-oophorectomy can be done. And Luna is not effective for management of pain. Presacral neurectomy relieves the midline pain, but it can cause bladder and bowel problem. And if it is going to be a unilateral endometrioma, maybe as I mentioned, unilateral salpingo-oophorectomy followed by LNG IUS gives good relief. So the surgical management may be preferred over medical management when there is definite recurrence of pain not responding to drugs, because the effect of drugs are short-lived. But we have to be very careful about repetitive surgeries because they alter the pelvic anatomy and the complications are going to be there. So this is a patient with a recurrent endometrioma with infertility. See, she had a recurrent bilateral endometrioma, and we need to have a proper counseling prior to doing a surgery for recurrent endometrioma, especially in patients with infertility, because this is definitely going to reduce the AMH level and her fertility may be hampered. So we have to be very careful when you are going to have a surgery for repeat endometrioma. So this was a outcome of laparotomy versus laparoscopy in women who were reoperated at the end of the 6 months. See, they had still recurrence of dysmenorrhea, deep dyspareunia, and pelvic pain even after resurgery. So hysterectomy may be the ideal if they have completed the family, but that too, ideal is to remove both ovaries, because by retaining the ovaries, the chances are almost 6.1 times greater than developing recurrent pain and 8.1 times greater risk of developing reoperation. Then coming to role of HRT, HRT definitely increases the incidence of recurrence by 30%, but the combination COCs can be used and Tibolon is ideally suited. And following surgery, if there is recurrence, most often it is the bowel recurrence, like how Dr. Shobana has already highlighted. So we have to balance the risk versus the benefit. If we feel that the risk is going to be high, do not give it. And if we feel that the advantage is going to be there, take a risk and give HRT, preferably combination of hormonal hormones, that is COCs or Tibolon. So benefit versus risk has to be made out. And again, hormonal replacement, I think this slide, when they have a control group versus estrogen, cyclical hormone, combined pills, they found out the group which had got no HRT had the least incidence of recurrence. So we have to be very careful. So a word about the infertility management in recurrences. ERT is always superior to the repeat surgery, and primary surgery has to be meticulous. There is always 50% reduction in the fertility after repeat surgery, and it has to be done only when ovarian endometrioma is quite large enough so that it cannot be managed conservatively during ART, or when you find difficulty in egg pickup, or when there is pain, or when there is suspicion of malignancy, we need to do or redo surgery. Otherwise, in patients with infertility, there is a big no for repeat surgery, and we have to manage fertility through ART. To summarize, recurrent endometriosis may be reactivation of existing post-therapeutic lesions or development of new lesions. Conservative treatment is the first line. Primary surgery should be done during follicular phase. Resect all the lesions. Pre-operative short-term medical therapy is of no use. Long-term medical treatment after surgery may prevent the recurrence. In clinical practice, it is troublesome to eliminate the risk of recurrence after treatment for endometriosis, and variety of risk factors have been identified, and they can be classified, and the patients can be educated regarding the incidence of recurrence and so on. And extensive surgery by senior surgeons can definitely reduce the incidence of recurrence. So the future may be better surgery, less invasive, less costly, more complete. Biomarkers may assess the increased risk, and biomarker-based intervention in selective cases can be tried. So I thank Madam Hepzibah, who is my mentor, for giving me this opportunity of sharing my views with recurrent endometriosis and its management. Thank you.
Thank you, madam. Thank you for your nice detailed discussion on this very problematic issue of recurrent endometriosis for the young women, as well as it is a tough problem for the gynecologist to handle such a issue also. So madam has mentioned in detail about the various risk factors for recurrence, the various dilemmas involved in clinical findings of endometriosis, the prediction of recurrence using biomarkers, the prevention, and so on, and also the various surgical measures available with the minimal invasive gynecological laparoscopic procedures. And she has also mentioned in detail about the role of COCs, LNGIUS, and Dynagist, and the role of cystectomy and the importance for the radical surgery whenever it is required. And she has also touched upon the infertility and recurrent endometriosis and how to go about with the individualized approach. Thank you, madam. Thank you for your detailed discussion on this very important issue of recurrent endometriosis.
Thank you, madam. Thank you.
Thank you so much.
I'm leaving, madam. Sorry, I'm leaving.
Thank you, Rani, madam. Thanks so much.
Spite of your
Welcome,
busy
Deepa.
schedule. Thank you.
Hi, Dhanlakshmi madam and Damodar. Nice to see you all. Bye.
Bye, ma'am.
Bye.
Thank you, Shanti, madam.
Yeah, thank
Yes,
you.
and
Thank you.
thank you for chairing the sessions. With this at good tempo, we will move on to the next next session. To chair this next session, may I invite Dr. Shanti Gunasingh, madam. She is my professor, and she is a consultant right now in Mangalam Healthcare, past president Oxy, and former director and superintendent of the IOG in the year IOG and KGH, former HOD, Thilpak Medical College. She is a project director, Center of Excellence for Tubal Microsurgery for almost 6 years, and past president, Women Doctor Association, vice president, Chennai Menopause Society. Participated in many radio talks, invited speakers in national and state level, and recipient of AL Mudaya Fellowships in 1993. Next, Dana madam. She is very popular among PG students, and she is right now professor, senior consultant, Department of Obstetric Gynecology, Sri Ramachandra University, Chennai, and she is treasurer Oxy. She is member UG Curriculum Faculty Credential Committee, 2016 to 2019. Honorary Joint Secretary in 2021 and ACOG Chairperson in 2015. She is also an invited speaker and chairperson at regional and state level conferences. She did lots of PG, UG division courses, workshops, CME, and outreach programs. Over to the cousins.
Thank you, Deepa. I thank Professor Hepzibah for having given us an opportunity to chair this wonderful session. And can I have the first CBTs of Dr. Damodar? We know that endometriosis is a disease of reproductive age. And we also know that 30 to 50% can be infertile. So because of all these reasons, fertility sparing surgery is very, very important for endometriosis. And to give us a glimpse on that, we have Dr. Damodar Rao, who is a consultant in OB-GYN, infertility and laparoscopy at Rao Hospital, Coimbatore. And he is renowned, he has been trained extensively in laparoscopy. And he also has a postdoctoral fellowship in endogynecology and reproductive medicine. And he has held various posts as Secretary Tamil Nadu, Joint Secretary Tamil Nadu IAG 2019 to 2022, and has been the Treasurer Kovai OG Society, and was also the organizing secretary of the wonderful Yuva Foxy South Zone. And the most important thing, he has been elected now as managing committee member IAGE, and we are really very happy about that. And he has received a lot of awards too. So let us hear what Dr. Damodar has to say.
Yeah, at the outset, I would like to extend my regards to Shobna ma'am and Hepzibah madam. Thank you for inviting me to give this lecture. And my regards to also Shanti ma'am and Vidya Tobi ma'am and Dhanlakshmi ma'am too. Without wasting any time, let's get into my topic. It's fertility preserving surgery for endometriosis. We've heard about medical management till now. Is my slide visible?
Yes.
Slideshow.
Yeah. Is it on slideshow now?
No. Now it's okay.
It's on slideshow now. Okay. Yeah. So yeah, we've discussed medical management till now, and we've also discussed about how endometriosis is a debilitating chronic disease, and it's worse than cancer. And it's always not like only surgical or only medical. It's always going to be a combination of both that the patient will need uh, for at least till she reaches menopause. So my topic today is mainly about endometriosis and infertility and surgery for it. So the patient will usually present to you with pain or ovarian cyst, or these are the main things they present to you with, or directly as infertility. Why is it a challenge? Because number one is the symptoms are not, are not, do not translate to what the patient has inside her body. Some of them can have severe pain and no symptom, severe disease and no pain at all. Some of them can have severe pain and very less disease. We do have good technology nowadays, like your ultrasound and MRI, which would help us. A good TVS scan, there's nothing like a good transvaginal scan nowadays, where you can even find out if there is involvement of deeper structures and DIE. So as a surgeon, why is it difficult? Because there's a lot of inflammation, everything becomes vascular. The moment you touch the structure, it begins to bleed. So surgery is difficult. And many times things become evident only after you put the scope. So you have to really sit down with the patient in the beginning, talk to her and tell her what are all the possibilities you can come across, what are the complications you can come across. You have to talk to her about, if she's only for fertility, you have to talk to her about her AMH. You cannot be very radical again. So you have to be very careful, in telling her a sort of, you can't tell her that, you're going to, you have to discuss colostomy also sometimes, but very mildly. You cannot tell them everything in a very blunt way. You have to be nice to them, talk to them, sit with them and tell them all that can happen. So I will divide my lecture into grade 1 and 2, which is minimal to mild endometriosis. And of course, grade 3 is ovarian and grade 4 is your DIE. Grade 1 and 2 endometriosis, of course, you don't really, you have to only suspect this, that is if the patient has some sort of pain or some dysmenorrhea or dyspareunia. And that's when maybe you might do a diagnostic lab to see if this patient has any lesions, or while doing diagnostic laparoscopy. There's no word such as diagnostic laparoscopy nowadays. Always go in for laparoscopy for doing something, right? Maybe for a tubal block or for a PCO puncture. And concomitantly, you might at the same time see that the patient has grade 1 and 2 endometriosis, and that's when you treat it. So if you see these lesions, definitely please go ahead and treat them. Don't just say, oh, they're very, very minimal, or I'm just seeing a few dots, I'm not going to touch them. Because endometriosis, as we know, just like the symptoms, it's the tip of the iceberg disease. We don't know what lies beneath. So even many times, just fulguration may not be enough. You might have to even go ahead and excise that particular peritoneal lesion. That's what is being taught nowadays, that go ahead and not just, if you cannot excise, then definitely at least fulgurate. But if you can excise the lesion, then, yes, go ahead and excise the lesion. Like, this is a very common site that you will see it around the uterosacrals or in the ovarian fossa. So if it's in the uterosacral area, and if it is medial to the uterosacrals, generally you're pretty safe. You don't have to worry about the ureter. So try and excise a lesion like over here. So if you do something like that, then the recurrence rate is a lot less. So this was a study done, a very famous study by Versilny et al., which said that if you at least ablate the lesions, the chances of pregnancy is a lot more versus no surgery at all. So in certain situations, yes, you will have to ablate it. Like, if you have a little bit of endometriosis over the ovaries or close to the tube, you cannot go and excise these structures. Yes, you just have to go and ablate these structures. Or sometimes earlier in my days of surgery, when it was in the ovarian fossa, it's usually in the course of the ureter. And that's when, if we are surgeons who only ablate the disease, we avoid this area. So now I have started, dissecting the ureter out in that area and excising the peritoneum around in that area. That gives much better results. Recurrence is also less, pain is also less. So overall, it's good for the patient to excise these lesions. So if the patient is aiming at spontaneous pregnancy and you come across stage 1 and 2 endometriosis, of course, perform operative laparoscopy, either excise or ablate. They say using carbon dioxide laser gives better results, but not everyone can afford a CO2 laser. Definitely, you can do it with your bipolar, the ablation. But the best thing that you could do for the patient is excise the lesions. That would be the best thing that you could do for the patient. Coming to grade 3 endometriosis, this is probably our most favorite, the ovarian endometrioma, right? You have to be very, very careful when you come across such a patient. Just because you've seen this patient, just don't go and jump on this patient for surgery. Because if it's peritoneal, you're not really touching upon her ovarian reserve. But when it comes to ovarian endometriomas, be very, very, think twice before you really do a surgery for the patient. Always look into a preoperative assessment is very, very important. See if it is unilateral or bilateral. Look into the patient's AMH, which is also very important. If the AMH is really on the lower side, then you again have to discuss with the patient whether surgery will help or what kind of surgery you're going to do. If the AMH is very low and if she has pain, probably you're just going to drain the endometrioma and not do anything to the cyst wall because you can reduce her ovarian reserve. So you really have to think a lot before you operate on an endometrioma. And again, compared to other cysts, there is no good plane between the cyst wall and the ovarian cortex. So you could be the best surgeon in the world, but whatever you do, you are going to cause some sort of a loss of ovarian tissue for her. So always look into her AMH and then discuss with the patient your way forward. So you have various surgical techniques, your cystectomy, vasopressin plus cystectomy, incision and ablation, and three-step technique, which is almost given up now. Cystectomy, we of course all know, once you drain the cyst, always introduce a third port. Your assistant will lift the ovary for you, and it really makes the surgery much better and meticulous. Always give traction, counter traction by walking close to where you want to separate the cyst wall from the cortex. Don't just hold it at the corners and yank it off. Sometimes the ovarian cortex can be pretty thin, and then you might just tear tissue and you're going to land up causing a lot more damage. So traction, counter traction. You can use a toothed instrument on the cyst wall and a non-tooth instrument, if possible, on the cortex. And then when you reach the end, that is when you reach the hilum, always be careful not to yank it off over there. What many people do is just use a harmonic and cut that area out so that you can leave a little bit of cyst wall over there, because if you try and pull out the complete cyst wall from the hilar area, it can start bleeding. And when it starts bleeding, you're going to apply some bipolar cautery over there, and that's going to cause further damage to the ovarian reserve. So that's one of the techniques to, further preserve the ovarian reserve. So the hilum is called the Achilles heel of the ovarian cyst, and it's always good that you take care not to damage the hilum. This is something that I've been using a lot, vasopressin, for the cystectomy. So basically, after you drain the ovarian cyst, what you can do is inject some amount of vasopressin, like you can see over here. And many times you will see that the bleeding is a lot less. You even get a good plane. You will never get a good clear pain. There will be parts like this where you will get stuck. It can be difficult, but on the whole, the oozing is less, and the amount of bipolar you're going to use is very less. So you may not have to use any bipolar at all. So it really kind of protects the ovarian reserve. This is also another video which uses let's fast forward it and come to the cystectomy part. So here you can see that the ovary has to be completely released from the ovarian fossa. You push the ovary up and see that it is completely mobile. Only that way you can do a good cystectomy. While doing this, be careful that you do not leave any ovarian cortex back on the ovarian fossa. That can also happen sometimes. So watch out for the cleavage plane and push it up nicely. And once you've completely mobilized the ovary, here you can see that vasopressin is being injected. You try and inject it in a layer between the cortex and the cyst wall. Here I was lucky enough, and you can see even it has created a plane, and the cyst wall is actually separating on its own just with the effect of the vasopressin. So there you can see it is completely bulging out. You can see the chocolate colored cyst wall that is bulging out. And all you have to do is hold the edges, tear it in order to make the cyst wall a little more visible. So you can see the inner layer over there, which is the cyst wall. And then, of course, you ask your assistant to support the ovary, and then you do a traction, counter traction, and you can see that all the fluid that you see is actually the vasopressin. It is not much of blood at all. And there's very, very less bleeding. In this video, I'll also show you, yeah, there again. So when you reach the hilum, use a harmonic and then, remove the cyst wall. Don't just yank it off. So here you can also see a little bit of peritoneal endometriosis. And if it is along the course of the ureter, if you're somebody who only ablates, you're not going to touch this at all. So it is always better to identify the course of the ureter, lateralize the ureter, and take out the peritoneum that is in this area. That way, the pain relief is much better and the recurrence rates are a lot lower. So you can see that the ureter is being lateralized there. And then you just remove the peritoneum in this area. So always put in a third port, get your assistant to lift structures, expose structures, because laparoscopy is all about traction, counter traction, and exposing the area very well. And here you can see that the peritoneum, you don't have to, well, in extreme cases, yes, you can. There is something called the butterfly peritonectomy, which I'll show you later. But otherwise, like over here, only the superficial peritoneum, if it is removed, your job is pretty well done. When I've come back, there's not much bleeding at all you can see in this area. And you can do a bit of pinpoint coagulation if required. That's about it. There is one more technique to the cystectomy. If it is a very, very large cyst, what you can do is drain the fluid, evert the cyst wall, and tackle it from the center. They say that the adhesions are the least in the center. Nowadays, I've started tracing out the ureter in most of the cases, because then if at all there is some bleeding, you're not worried about, applying your bipolar at any point, and your hemostasis is much better. That way adhesions are a lot less. So I'll just get to the point of the cystectomy. So here, there's always a area which is, a punctum, which is the thinnest area. While mobilizing the ovary, it will get released, and the chocolate colored fluid will come out from there. And so here you can see that I've mobilized the ovary, and what I do is evert the ovary. Here also I've injected a little bit of vasopressin in the center, and you make a cut with the scissors in the center of the cyst. So there you can see I've already got a good plane, and you extend this incision from one end of the ovary to the other. And then you peel out the cyst wall from the middle to the periphery. So this is an everted ovary where you can see the cyst wall, and then you peel out the cyst wall from the middle to the periphery, because the center part of the cyst is where the adhesions are the least. The periphery is where the adhesions are the maximum. There are even surgeons who trim out the periphery completely. That way, it's easier to remove the cyst wall, and recurrence rates are also less. But all this depends a lot on the AMH of the patient and what you are planning for her. So this way you can see that the cyst wall is actually coming out beautifully. So the effect, there are a lot of studies which say that vasopressin is great, and it also preserves, the fall in ovarian reserve is not as much as without vasopressin. So it is good to use vasopressin. Sometimes vasopressin may not be effective. Even after your cystectomy, it can bleed quite a bit, like it is bleeding over here. So don't go and apply your bipolar everywhere on the ovary. You can just take a bite and control the bleeding, which will be more than sufficient. So then there are also discussions about which might cause more adhesions, using a bipolar or using a suturing. They say that both have similar results, but if there's too much of bleeding, I think taking a bite would be much, much better. Hemostatic sealants, again, there have been mixed reviews, and small bowel obstruction has also occurred, so it's still debatable. 3-stage procedure, which is almost given up. The patient has to you incise and then you take her for surgery, you incise the cyst, give her GnRH, again you take her back and then you do a cyst wall laser ablation. It's almost given up because the patient has to undergo surgery twice. This is something that has been coming out of recent. Dr. Horace Roman from France has been doing this a lot. So I'll just, video is not, video should be here. Okay, videos. So basically uses plasma energy to ablate, like how I everted the cyst wall, they evert the cyst wall and it just uses plasma energy on the cyst wall. It is like laser, but not as expensive. And he says the recurrence rates are less and the damage to the ovarian reserve is also not much. So you don't do a cystectomy, you just burn out the cyst wall with plasma energy. So the patient is for spontaneous conception, then an ovarian endometrioma, yes, if it is unilateral and an AMH is good, go in for surgery, excise the endometrioma capsule instead of drainage. Always the pregnancy rates are better and recurrence rates are less. That's what ASRM says. If the endometrioma, there is, back in the day, they spoke about a size of cutoff of 3 centimeters. Now there is no evidence about the size of the endometrioma. One of the major indications for surgery is pain. So the patient really has pain, then definitely you have to go in for surgery. Or if the patient is for IVF, and then you think that the cyst is going to come in your way of the ovarian pickup, then you probably have to go and operate on such patients. Okay, this the slide is here. So this is not my video. This is Horace Roman's video where he basically everts the cyst wall, and what he does is uses plasma energy on the cyst wall, and the whole cyst wall is burnt out. So the depth of how much it burns is a lot less than bipolar. It's very similar to laser, he claims, and hence the damage to the ovarian tissue is not much. And of course, the cyst wall is also burnt out, and hence the recurrence rates are a lot lower. Ethanol serotherapy is also being tried, where through laparoscopy you drain it, and then ethanol is injected into the area between the cyst wall and the cortex. I personally don't have any experience with this, but this is something that's again, coming up slowly. This is what Madam was talking about, Ramani Devi Madam. This is the butterfly excision. So this is usually done in cases where nowadays the dictum is usually if it is DIE and the patient does not have too much of pain, yes, she can go in for ART directly. But this is reserved for a few set of patients where they've already had a couple of IVF failures and you don't know what to do for them. Then you can definitely go ahead and operate on her. Even if she's already had a surgery, you go and look at the peritoneum of the patient. Basically, it's the mnemonic called So Sure. It's basically sigmoid mobilization, ovarian mobilization, suspension of the ovary and uterus, uretrolysis. Then you enter the rectovaginal septum, entry into the pararectal spaces, and resection of the butterfly area. That is what the So Sure resection means. So, yeah. So I think most of the surgeries nowadays start off with mobilization of the sigmoid colon. That is what we've all been doing. So it really falls off the rectum. You have to flip the sigmoid colon in such a way that the ureter is exposed. That is why this step is done. So here you can see the ureter clearly over there. And once this is done, ovarian mobilization has to be done. So basically, that you've already seen in my previous videos, you push the ovary away from the ovarian fossa, and you can see that it is slowly being released. If there is a chocolate cyst, do a cystectomy if required. If it is, if her AMH is again good, if her AMH is on the lower side or already operated ovary, then maybe you don't do much about it. That is the other ovary that is being mobilized. And then you can antivert the uterus. If you don't want to put a manipulator, you don't want to put anything inside the uterus, you can take a hitch. And you can also suspend, you have to suspend both the ovaries. That way you get a good vision of the rectovaginal area of the POD. And then you do a ureterolysis on both the sides. This is a very, very important step. Doing ureterolysis on both the sides is very, very important, so that the ureter is out of harm's way. And that makes your surgery a lot more, a lot faster. You're confident about what you're doing. And next, what you do, what is remaining is the rectum, right? And the adhesions of the rectum with the uterus. That is what is remaining. So this pararectal area is very, very important. Pararectal space, the medial pararectal space is very, very important. That is the space between the rectum and the ureter. And you get a good plane over there. So like how in your bladder, you approach from lateral to medial, here also for these surgeries, you can approach it from lateral to medial. And once you have only the center lesion in the center, you separate the rectum from the uterus. So you can do it either way. You cut through the nodule and then you place the lesion on the rectum, and then you do a rectal shaving. Or if you're able to get a plane between the rectum and the nodule, you can leave the nodule on the uterus. So here the nodule is left on the uterus and the rectum is pushed below. That's the pararectal spaces being developed. And finally, once you've done that, the rectum is mobilized and you have only the lesion in the center, you do the butterfly resection. That is from one lateral ovarian fossa to the other ovarian fossa. So what it basically does is it removes all the or most of the peritoneal lesions, which probably have an effect on fertility. Again, Horace Roman is a surgeon who's done a lot of this, and he says that many patients have conceived spontaneously also. And definitely IVF results are also improving. So he has a full study on this. This is called the butterfly resection technique, because what you remove at the end is in the shape of a butterfly. Yeah, so you can see the two wings of the butterfly over there, and that's why it's called the butterfly resection technique. So that's what it looks like at the end. So yeah, I'd like to conclude by saying definitely, even though I love laparoscopy, differ from surgery as much as possible. If you're going to operate on her, let the first surgery be hopefully her only surgery and the best surgery. That's wishful thinking. I mean, usually these patients might land up with multiple surgeries, but try and do the best. Try and remove as much as lesions as much as possible. And nowadays we have great optics, 3D, 4K, a lot of good teachers in India. Standardization of technique is also very important. Now this technique has become very, very standardized. That is, you open up the pararectal, identify the ureters, open up the pararectal space, and then deal with the nodule. This is a very, very standardized technique now. That is the same technique even for hysterectomy if you want to do. So yeah, I think as technology has been evolving, we as surgeons also have to evolve and give the best to our patients. Thank you.
Thank you very much, Dr. Damodar, for your lucid talk. And it was really very nice to hear you talk about fertility sparing surgery. And we know that counseling is the sheet anchor, and how much we tell the patient or how much she wants to know, that is also there. It is really very difficult, especially in an extensive endometriosis.
I also left out tubal disconnection in my talk, which is also part of enhancing fertility.
IVF outcomes.
Yes. That is also, if you tell them, many patients run away if you talk to them about tubal disconnection. So.
Okay. So, and thank you for the nice tips that you have given. Thank you very much.
Okay.
I shall, now Dr. Dana will take over.
Good evening, ma'am. Good evening, Hepzibah ma'am, for giving me this. I thank you very much for giving me this opportunity to chair the session when Dr. Vidya Tobi is going to give a talk. And can I have Dr. Vidya Tobi's slide, please? Dr. Damodar, let me take this opportunity to congratulate you on your getting elected as a AG Managing Committee member.
I'd like to thank all the people of Tamil Nadu for all the support. Thank you so much.
Chitrakala.
Tamil Nadu and Kerala and whole of South, the whole of India.
Yeah.
Thank you. Thank you.
Chitrakala.
Well, pray for both of
Can
you.
you so,
Deepa, can I read from my?
Yes, madam. I think
Yeah,
Chitra is. Ma'am, yeah, you have a CD with you, ma'am?
Yeah.
I've got.
Yeah.
Dr. Vidya Topi, is she available?
Yeah. Madam is there. Madam is.
She is going to, Madam, welcome you, Madam, for this evening CME of Chennai Menopause Society. And we are eagerly awaiting your speech on alternative management of endometriosis. I'm happy to welcome you to Chennai. And she was a chairperson, Food, Drugs and Medical Surgical Equipment Committee of FOXI 2018 and 20. I have attended many CMEs conducted by you during that pandemic. Best Committee FOXI Award to Dr. Dara Ansotia Award in 2020, ICOG Governing Council member from 21 to 23, FOXI Champion Award in 2019, and she's organizing chairperson for KSO GA 2016. She's initially secretary for Bijapur Society in 2007. Subsequently, she became president for the same society in 2009. She had given several publications and various books, and she has contributed to FOXI Focus, and she has been an invited speaker at various national and international conferences, and organized various CME workshops and awareness program. And she is advisory faculty of boards of Rajiv Gandhi University of Health Sciences, and she had been both UG and PG teacher for the last 30 years. Madam, the floor is yours. Take over, madam.
1 minute, please allow me to share the screen.
Sure, madam.
I am talking from my mobile, so I'm just connecting myself from the laptop. Please, madam. Thank you. Give me some time. Hello.
You can switch off your mobile, madam.
Yeah, I have switched off and hope my screen is seen to everyone.
Yes, madam, and you can go to slideshow from first slide, madam, because it is the 6th slide.
No, I have, yeah. Now I have on my slideshow.
Yes, no, you are on A2.
I don't know what has happened again.
And you can present it that way only, madam, without slideshow.
I can present like that only?
Yes, ma'am. Yes, ma'am. Still visible.
Yeah. So thank you very much.
Madam,
Chennai,
share screen.
PPT not seen, madam.
Share screen, madam.
Yeah. Okay, I'll just share screen again. If something is wrong. No, I'll just try once more. Last. Yeah. Is it visible?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
So I will be doing the screen share.
Already your screen shared. Slideshow, please.
Slideshow. Thank you very much. So I have made my slideshow. Thank you very much, Chennai Menopause Society and Dr. Hepzibah Madam and Dr. Tamil Selvi and Deepa. Really, it is a pleasure amongst all the stalwarts of Chennai. I can see Dr. Shanti and Dr. Dhanalakshmi, everybody, my dear friends, and thank you for inviting me for such a different topic, that is alternative medicines in management for the endometriosis. So endometriosis, as all of us know, that the incidence is around 10 to 15%, and usually the patients, they present with the chronic pelvic pain, severe dysmenorrhea, subfertility, and these all affect the patient's quality of life. In recent years, the complementary and alternative medical treatment for endometriosis has become popular owing to the effectiveness at relieving dysmenorrhea mainly. And second is, they have observed some shrinking of adnexal masses, promoting pregnancy with few adverse effects when compared to other treatment. Though there is a lack of research specifically addressing to the impact of non-medical strategies.
Sorry
Yes.
to interrupt, ma'am.
Yeah.
Your slides are not changing, ma'am. It's still in the first slide, ma'am.
I don't know what has happened. Can you share the slides?
Sure, ma'am. Sure, ma'am.
I have sent you by mail, no?
Yes, ma'am. I received, ma'am. I will do that, ma'am.
Yeah. Please do that. So till then, I was just talking about the various research which was addressing the impact of non-medical strategies in the treatment of endometriosis related symptoms. More studies are emerging. So it seems evident that women are searching for an alternative ways of managing and coping without or alongside surgical and pharmacological interventions. So next slide, Chitrakala. So I was in next slide. Yeah. This was a slide. Yes. Next slide. So as I finished my this one. So complementary and alternative medicines in the recent there are few studies, and they gave certain questionnaires, and they found that more than 60% of Swiss, Austrian, or German endometriosis patients, they used the complementary and alternative medicines. And we all know in India also we do use, but we never document. The study also reported some link between higher usage of these complementary medicines and dissatisfaction with healthcare. So always, whenever we are using allopathy medicine, we just, if they don't work, our Ajji, Nani, they say, this will work. Lavanka tel, like that, they are there, but there is no evidence-based. So this data shows that there is clearly a place for non-surgical and non-pharmacological alternatives for women diagnosed with endometriosis. Next slide, please. So the interventions and approaches, these all depend on the impact of the condition, one thing, the patient's priorities and the preferences, and third is the availability of the services. There are several different treatments such as transcutaneous electrical nerve stimulation, which we call it STENS, psychological and physical therapy. Also, they are being offered in adolescents, specifically with endometriosis. There are also some of the self-management strategies which highlight at least 70% of the people with endometriosis, they use heat, diet, meditation, breathing exercises, non-prescribed drugs, and even sometimes alcohol. So these are the recent some of the studies I went through, and they have found that some of the self-management strategies they have used. Next slide, please. Yeah, this was a really great article. This was a review article which is published in Hindavi, and they have studied various complementary and alternative medicine for endometriosis. From this review only I have taken as a base, and I have formulated my all the slides. Next slide, please. Yes, the complementary and alternative treatment for endometriosis includes one is herbs, extract and patent, acupuncture, microwave physiotherapy, and Chinese herb medicines. These are the basically these are the 4-5 complementary and alternative treatments which are mostly studied. Next slide, please. So, first one is the herbal products. They include use of herbal formulae, 2 or more separate herbal ingredients selected that are prepared as a boiled decoction, and then they are processed as a herbal extract, or they can incorporate in pills or capsules. So these are the common things they use for any herbal preparations. Next slide, please. Hello, Chitrakala. Yes. So herbal extract therapies are herbal extract which are commonly used as turmeric, resveratrol, then green tea, then retinoid, saponin, rhizoma, zidori, water decoction, and these all play an important role in endometriosis dysmenorrhea by affecting one thing is cell proliferation, second is apoptosis, angiogenesis, and inflammatory microenvironment. So these are the various therapies with the use of herbs. Yes, next slide, please. Yes, one thing is how they act. One is a mechanism. One thing is they reduce the viscosity of the blood. They improve the pelvic microcirculation. It inhibits the expression of inflammatory factors like we know interleukin-1 and interleukin-6. Reduce the expression of prostaglandin E2, F2 alpha, and nerve growth factors. They inhibit the uterine smooth muscle activity and relieve uterine muscle spasm. So these are the various mechanisms by which they act. Next slide, please. So these can be evaluated by various clinical parameters, how they have acted actually. So they have found out that endometriotic lesion size, which they measured by ultrasound examination, pelvic pain, dysmenorrhea, which is measured by the clinical pain visual analog scales, that is VAS, and implanted endometrium size, which is measured by weight and volume. So these are the things they have evaluated after the therapy. Next slide, please. This is, we know that this resveratrol, which is a polyphenol extract from grapes, mulberry, and other plants, and due to its antioxidant property, it has shown to potentiate the effect of oral contraceptives in decreasing dysmenorrhea by inhibiting aromatase and COX-2 expression in endometrium and endometriosis patients. And after use of this, it was reported that there is increased peritoneal levels of free oxygen radicals as seen in endometriosis. They were suppressed. So this is the main advantages of use of resveratrol. So next slide, please. And this is another one, which is extract from the green tea and which possesses the anti-proliferative, anti-angiogenic, and pro-apoptotic effect, and thereby it can reduce the size and weight of the lesion. So it is called as EGCG, which is very much available in green tea. So we often tell the woman to drink green tea. So green tea has got this extract of epigalactose, echin, and 3-galate. So this is very useful, and they have found there are some studies available, and they found that there is a reduction of the lesions. And there are various studies reported that even this EGCG can suppress VEGF and VEGFR2 in endothelial cells. And various studies also showed that it also prevents the fibrosis and progression in endometriosis and helps in inhibiting proliferation, migration, and invasion of endometriotic cells. So various the modification of our diet and nutrition. Whenever I have some of the nutritional interference also. There are various studies, as Dr. Shobna was mentioning. So these are the studies which they have published about the endometriosis and nutrition. Next slide, please. Yes, this is another one. It is an isoflavone, genistein. which is isolated from soya, and it possesses phytoestrogenic and antioxidant effect. There are various studies again which reported that this molecule decreases the surface of the endometriotic implants by its anti-angiogenic and anti-proliferative mechanism. This genistein also decreases the expression of various again pro-inflammatory factors like interleukin 6, TNF alpha, and COX2. So this is again one of the soya. From soya also it helps. Soya, eating soya. Next slide, please. And this is another, they have prepared some water decoction, rhizome zidori water decoction. It is derived from the dried tuber of curcuma Ficolis valeton and helps in down regulation of JAK2 and STAT3 phosphorylation, and these are the various biochemical changes which occur, and there is again reduction of JAK2 STAT3 levels in the ectopic endometrial tissue as seen in, they have studied of course in the rat models of endometriosis in the rats. Next slide please. There are various medicinal plants we know, and if you go to the Kerala side, Shobna might be knowing, they use various Ayurvedic plants. If you go to some any jungle or anything, and we find in Kerala especially, they have got Arya Vaidashala, big Ayurvedic, and we never published the articles, but definitely there is science behind it, and these are the various plants which are available. This is another plant which is Asteraceae and have been used for years in the management of infertility and dysmenorrhea. We know Ashoka also. It contains many bioactive compounds like flavonoids, stearolic acid, coumarins, and many studies reported that it has got anti-tumor, anti-spasmodic, and antioxidant properties. Next slide, please. And this is very commonly we use in kitchen, right? Garlic. The scientific name for this is Allium sativum. It becomes, we know that it belongs to Liliaceae family, and it possesses some antioxidant property. The constituent of this garlic, what we talk of, is the diallyl trisulfide. It inhibits angiogenesis in human endothelial cells. It also suppresses the secretion of pro-inflammatory cytokines. Ultimately, all act through the same mechanism. And also it enhances the secretion of interleukin 10, which is an anti-inflammatory cytokine. So garlic is very useful, they say, and eating 2 garlics every day will definitely have a better effect. Next slide, please. And this is a turmeric, again from our kitchen. And turmeric, which is a very major bioactive compound, which is represented by curcumin. It increases the activity of interleukin 10. It is an anti-inflammatory cytokine gene promoter. And in recent study, it was reported that ethanolic extract of curcumin longa in endometriosis decreases the oxidative stress. But again, eating too much curcumin is also very dangerous. There are certain studies which say, they say that even cholelithiasis is very common if you eat too much turmeric. So it should also be eaten in a limited amount. Okay, next slide, please. Now Chinese people are very clever, as we know from our recent attack of virus from them. Now they have patented this medicinal therapy as well. These are based on Chinese medicine theory, using this Chinese herbal medicine as raw material. And they include various, I cannot utter their words and I don't want to utter also. There are various ingredients like Guzi filling capsules, Elaine capsules, the Danbai capsules, and they have all patented. Sanji analgesic capsule, then Fucang paste. These are all available, and these all have active ingredient which has anti-inflammatory, analgesic, and immune regulatory effects. And there are many clinical studies that have shown that it can effectively reduce the level of CA125, CA199 in endometriosis and can improve the menstrual cycle and menstrual volume. It also helps in blocking signal transduction pathways between cells and inhibit the abnormal proliferation of endometrial cells. Next slide, please. Yes. So this is one capsule which is called as Elan capsule. It also helps in reducing the promotion again of vascular proliferation, adhesion formation. It inhibits the expression of soluble intercellular molecule 1. There is an RCT, that is randomized control trial, where the total effective rate of dysmenorrhea was decreased from 84 to 48% with the use of these capsules. So there are other capsules which are available, which also reduces the concentration of prostaglandins, which can also reduces the pelvic stasis and improves the pelvic microvasculature and relieves the pain. So these are the various capsules which they have patented. Next slide, please. Now I was talking about the Chinese medicine. There is an associated problem with the European clinician. What is that? Is applying this therapy in the Western medical setting, because always we all believe in the evidence-based strategies. So there are only 2 studies which were reviewed as they were of better quality. There are many studies available, but they have got very less number of patients which they have studied in that. They're too small to apply for any statistical analysis as well. There is one second study even did not find any significant difference between the pain scores in the 2 groups of the Chinese medicine diet. However, there was no blinding and no placebo. So how much we have to believe? Sometimes we give empirical therapies, not these. So that's what happens. Next slide. Now, whenever we talk of non-medical management strategies which are effective for the symptoms associated with endometriosis, mainly we talk of pain and quality of life. The most commonly used is acupuncture. We talk it as a safe, easy to perform, but we have to learn the technique again. It requires needling, auricular pointing, and moxibustion. It relieves the pain in the central and peripheral regions. For how it activates the neurotransmitters, modulators, including serotonin, norepinephrine, and adenosine. So there are again various clinical and animal experiments which concluded the different mechanism of acupuncture treatment for dysmenorrhea. That again causes relaxation of the meridians and promotion of blood circulation, they say. And there is an activation of various neurotransmitters, reduction of VEGF, and regulation of abnormal prostaglandins. Next slide, please. So sometimes they have done this acupuncture combined with moxibustion treatment. It is very common practice and effectively stimulates the regulatory function of meridians and collaterals, and thus improves the local blood stasis. There is a warming of needle moxibustion that combines acupuncture, moxibustion, and involves the wrapping of moxa on needle handle. There is ignition. You can see here some fumes are coming. So igniting during the needle retention process. The needle body transfers the heat to the acupoint to treat the disease by warming the meridians and promoting blood circulation. This is how it acts. Next slide, please. Then another is auricular acupoint treatment. It is believed that acupoint on the ear can reflect. Maybe that's why we pierce the ear, no, with newborns. There are some points on the ear. So they say that this treatment, acupoint on the ear, can reflect the general health of a human body. This treatment is used for pain relief in inflammatory disease, endocrine, and metabolic disorders. It can be used as daily care treatment for endometriosis to improve the patient's quality of life. One study showed that auricular acupressure could relieve uterine smooth muscle spasm by reducing the secretion of, again, serum prostaglandins. So this is how it acts. Next slide. There are other methods like electropuncture. It is a modified form of acupuncture which uses electrical stimulation and can even effectively improve the blood circulation. It blocks the pain by activating various bioactive chemicals through the peripheral spinal and supraspinal mechanism. Next slide, please. Now, again, I brought this slide because there are various enema, the medicines which are also used for enema, this Chinese herbal medicine, and they act through the same mechanism. And they also show that there is decreased level of serum CA-125 and various anti-inflammatory and pro-inflammatory. This one, there is a decrease in these various bioactive inflammation and pain as well. So this Chinese herbal medicine enema combined with microwave physiotherapy also they have tried, and this therapy it uses a magnetocaloric effect of microwaves on the tissues to stimulate different areas through around the rectal wall also. So they have given enema, they have given microwave physiotherapy, and they have tried many things, and they have observed that it shrinks and softens the endometrial sac. It increases the blood circulation around the lesion. Also, it improves the capillary permeability, relieves the smooth muscle spasm. These are the various actions are taken, are given by this enema and microwave physiotherapy. Next slide, please. Chitralekha, can you move the slides? Yeah. So in a nutshell, you can see the various herbal products, what are used, the clinical indication for what it is used, like endometriosis with chronic pelvic pain, dysmenorrhea, and infertility. The specification, the practitioner judgment, for what purpose it is used, and the efficacy. So this is, and the precaution you should take. So if you are prescribing the acupuncture for the patient, if the patient has got these symptoms like infertility, pelvic pain, and dysmenorrhea, you have to choose certain acupoints. So that's why you have to take proper training of acupuncture. So, and also additionally, you can also try with the moxa, moxibustion also. The main thing is some patients may have fainting during this acupuncture. Then there is enema, whenever the Chinese herbal medicine enema. So in these patients, some of the patients like irritable bowel syndrome patients, we cannot use these enemas. Likewise, microwave physiotherapy, you should also see that whenever we are giving this physiotherapy, though it elevates the dysmenorrhea, shrinks the endometrial lesions, we have to see that it should be appropriately adjust the distance of the microwave physiotherapy equipment, so not to scald the patient. So this is very important whenever you are using this alternative therapy. So you should know where to use, how to use, and we should know the side effects also of these alternative therapies. Next slide, please. Yeah, there is again, there are some studies on physiotherapy, massage, trigger point release therapy. So these, there are recommendations for physiotherapy that should be given with caution. It should be given always with caution. And I just went to the various review of literature, and the review found 6 RCTs with significant heterogeneity and often combined with psychological and medical management, making it impossible to establish the standalone value of physiotherapy input. So physiotherapy is again one alternative therapy which is used. There are again 2 studies which were retrieved the evaluating manipulations and massage for the relief of endometriosis associated pain, but there are too low quality to support any recommendations. So about the physical therapy, routinely the various our NICE or ISHRE, they don't recommend because of low quality of support or the evidence on that. Next slide, please. So in conclusion, what is the current, whatever the current literature which is available, there are no recommendations can be made about the physical therapies, exercise, or their benefits regarding the improvement of quality of life and reducing the pain. The evidence is very poor for the benefit of physiotherapy with pelvic pain, and adverse events are very unclear. It is very difficult to extract any specific components of physiotherapy interventions as the human interaction. Suppose I do physical any exercise, my reaction will be different than the other person. So it is all the mental makeup and the reaction. So it all depends on the communication skill, patient-centered care. It all affects all the interventions. So there are no recommendations for the exercise and activity. But we all know that exercise and activity, they are considered the part of healthy lifestyle. Always we talk, whenever we talk of obesity, we talk of PCOS, for any purpose, anything. And after this, midlife we always talk of healthy lifestyle, and so the guidelines decided the cautious recommendation with a note on the need for the further studies. So whenever we don't have any studies, we always talk of need for further studies. So the guidelines says the same. Next slide, please. Yeah. This just I wanted to include that there are again various Cochrane reviews about this transcutaneous electrical nerve stimulation. There are various RCTs also available. So they found some improvement in the term of stress reduction or improvement in the quality of life. They have found that whenever they are using this electrical nerve stimulation, but they have also there are some studies they found no improvement also. So it all depends how you choose your patients, how you impart a certain type of alternative therapies. So it endometriosis symptom severity scale you should find out and apply this transcutaneous electrical nerve stimulation, and then you have to judge how is a pain relief. Next slide, please. There are 3-4 studies. I just took these studies, and they found that some of laser therapy they have tried. So the effect of pulsed high intensity laser therapy, 3 sessions per week for 8 weeks, which was compared with sham laser treatment, both addition to the standard hormonal treatment. They have compared with the hormonal treatment in 2 groups, and they found that in 85% of the patient in active treatment group, they reported complete or excellent pain relief, and there was a significant increase in the quality of life in endometriosis health profile. So they have tried laser also, but again there is no recommendation can be made based on some small studies. These studies regarding electrotherapy or laser therapy and effect on the quality of life or pain in women with endometriosis. But one should know these are the types of treatments which are available. Next slide, please. Chitralekha, can you change the slide? So coming to the nutrition, nutrition is very close to me, as I worked for Food, Drugs and Medical Surgical Equipment Committee, and I had many webinars and many awareness program about nutrition. Now, in nutrition and endometriosis, so there has been much postulation that diet may affect endometriosis symptoms, which may be based on the observation. Again, that diet can affect several processes such as inflammation, prostaglandin metabolism, estrogen activity. And again, there are very few studies of limited quality evaluating benefit of dietary intervention and their effect on endometriosis symptoms. So we have got vast field to do research, search and research on nutrition and endometriosis. Next slide, please. Omega-3 fatty acid, fish oil, it reduces the inflammation, we know, improves the immunity, we know, antioxidants, vitamin A, C, D, E, and B vitamins, trace elements like magnesium, calcium, zinc, and selenium. We all know in Corona period that these are very important immunity boosters. So these also help in endometriosis. Next slide, please. So these are the various reviews. There are reviews on antioxidants, gluten, and soya. Okay. So nutrients with direct or indirect anti-inflammatory properties might have an effect on endometriosis related pain, but evidence is not yet available for the development of specific endometriosis diet. With regard to the dietary intake, the study of these Averis, I just went through, and they found significantly lower intake of these patients with polyunsaturated fatty acids and significantly higher intake of fiber in women with endometriosis. So higher fiber intake may help. No difference in antioxidants in the diet of the woman with or without endometriosis. And some of the studies, they found that these women have lower dietary intake of antioxidants like A, C, and E in these women. So if we increase these antioxidants and trace elements, and we should find out how much is the effect on the endometriotic lesion or the symptomology of the endometriotic lesion. that we have to find out. Next slide, please. Again, this is a Professor Hansen. He has included 6 studies reporting that omega-3 fatty acids. It has got a positive effect on dysmenorrhea with reduced pain intensity, duration, and lower use of painkillers. So this is another study in 2013 he has done. One more study, they also found that there is a decreased pain score after using fatty acids. Then vitamin D is another important nutrient. And there are various review articles which there are 2 studies which I found which has got opposite results again. Small RCTs are there which compared the effect of vitamin D supplementation, fish oil, and they compared with the placebo and pain score, which reported significantly improvement in the pain score after vitamin D supplementation. So more modest improvement was observed in the patient receiving fish oil. So fish oil, omega-3 fatty acids, vitamin D, these are the positive things we can ask our patients to take. Next slide, please. So I'll not go the study. These are the various studies, and they found that this gluten, dairy products, and if they increase the carbohydrates, and they should also increase the fruit and vegetable and fish, definitely there is a decrease in the symptomology again of endometriosis. So we should also have nutritional advice of these endometriotic, and whenever the patient has endometriosis. Next slide, please. So in summary, based on the current literature, no recommendation can be made about the use of nutrition or traditional Chinese medicine to improve the quality of life. Then reduce the pain in the woman of endometriosis. So literature will not give you any support. Always these alternative medicines we have to choose ourselves, and there is very less evidence which is available. Only few studies, clinician may suggest the fish oil as an alternative to the more harmful anti-inflammatories. The literature and research into Chinese medicine are primarily concerned with the interventions and outcomes that are not commonly used in Western medicine. With regard to the nutrition, data are summarized in well-constructed systematic reviews, but included data is derived from again small studies without proper controls, limiting the meta-analysis and any firm conclusion. So we have to draw our own conclusion only from the small studies. Next slide, please. So about the infertility. So what are the non-medical management strategies which are effective for the infertility associated with endometriosis? So there is again no clear evidence that any non-medical intervention for women with endometriosis will be of benefit to increase the chance of pregnancy. There are no recommendations to support any non-medical intervention, nutrition, Chinese medicine, electrotherapy, acupuncture, physiotherapy, exercise, psychological intervention to increase fertility in women with endometriosis. The potential benefit and harms are unclear. This is, I have taken from ISHRE 2022, recently it has been published. So I took from what are the recommendations of ISHRE. They have told about these non-medical management strategies. Next slide, please. Yeah. So these are addressed nicely that whenever there is unclear etiology or unclear prognosis, patient comes to you by pelvic pain or painful periods, you often, sometimes they definitely need long-term support. And this long-term supports and coping of these all symptoms. So NICE proposes that you can use wisely some of the complementary medicines. Yeah. Next slide, please. And these are the guidelines which recommend that you have to, clinician should discuss what are the non-medical strategies to address the quality of life, psychological well-being in the woman, managing the symptoms of, for the managing of the symptoms mainly. And however, again, no recommendations have been made by ISHRE for the any specific non-medical interventions like Chinese medicine or anything. These interventions to reduce pain or improve the quality of life life measures in women with endometriosis, as potential benefits and harms are unclear. We don't know what are the contents of those capsules, Chinese medicine, though they are patented by them. We don't know what is inside. So we are really fearful to use these Chinese herbal medicines. Yeah. Next slide, please. So again, these are the conclusion. Why I have put this slide is what are the obstacles? Mainly these 3 points I just wanted to make that what are the obstacles for choosing this? One is selective publication of only positive results are published with varying study qualities and standards. Second is lack of large sample size and randomized control trial. And the third one is lack of confirmatory animal studies with therapies such as auricular acupoint or any Chinese enemas or microwave physiotherapy, psychological intervention. There are no proposed protocols. And the molecular mechanism of some of these complementary alternative therapies need to be further investigated and confirmed as in future. So we have to do much research in these complementary medicines, but definitely I can say that psychological support or physiotherapy, we know that endometriosis is enigma, but definitely we have to do much research in this complementary medicine. We have Ayurveda, we have got Unani, we have got homeopathy, but much studies are required to stamp that this is the treatment for endometriosis. Next slide, please. Yeah. So this is a summary and conclusion. The active principle of complementary alternative medicine therapy has strong scientific foundation, they say. Researchers are increasing, they have increased interest in this area of medicinal treatment. But standardization of effective alternative therapies are still needed. However, including managing the pharmaceutical form of herbal agent and controlling the quality of acupuncture methods, that is very important in order to increase the benefits of these alternative medical intervention to the patient with endometriosis throughout the world. Thank you very much.
Thank you, Vidya Madam, for taking us through all the alternative medicines for endometriosis. Many of the medicines we knew, but then we do not know how we can apply it in our daily practice. And of course, as you said, we need CTs in this segment to help our women who suffer from endometriosis at large. Thank you so much, ma'am, for being with us.
Thank you all. Thank you all.
Thank you, Vidya Madam, and thank you, Dr. Damodar, and thank you, Chairpersons, Dana Madam and dear Santi Madam. And now may invite our Secretary, Dr. Tamil Selvi, to deliver our closing remarks. Dr. Tamil?
Still there?
Over.
Tamil is not there?
Ma'am, Tamil Selvi ma'am is there, ma'am.
Oh, is there? I know. That's the reason I just called her.
Yes, ma'am, I'm trying to unmute her.
Okay.
Tamil is not there?
Tamil is there, madam.
But yeah, why don't you conclude, Deepa?
Okay. Okay, madam. Okay. Thank you all. And at the outset, I would like to thank the Shield Healthcare teams for Chitrakala and their team for constantly supporting all our meetings, and the delegates patiently attended and maximum participation in all our Chennai menopausal meetings. And I'll thank our guest of honor and chief guest Shobna Mohandas and Dr. Sanjeeva Reddy for taking their time and facilitating our meeting. And I thank President Hepzibah Madam and all the speakers, and our chairpersons kindly agreed and sharing their knowledge with us. Thank you, Madam.
Thank you. Thank you. Thank you so much.
So
It
much,
was
ma'am.
nice attending it and lovely talk
Yes.
with
Yeah, lovely talk. We learned a lot of new things.
Ayurvedic medicines are very
Yeah,
bitter. I tried
alternative
giving it.
medicine.
Patients don't take only.
No, I mean, at the final resort, I think they will take it when they are fed up with all of the drug and recurrent
It's
thing.
very bitter. That
And commonly, we are also using that M2 tone and Charaka, these things.
That is not there. The real Ayurvedic medicine are that Arya Vaidyashala, that is very thick, very bitter.
Arya Vaidyashala at Kerala, we want to visit sometimes.
Yeah, it's very bitter.
Thank you, madam. Thank you, Dr. Shobna, Dr. Vidya, Dr. Ritu.
Yeah, thank you very much. Thank you.
Thank you.
Yeah,
It was,
nice meeting all of you. Bye.
Thank you,
Thank
Shobna.
you. Yes. Can we all leave?